coming in. Thank you so much for joining. I'm joined today by Dr. Justin Hauxwell and Dr. Bettina Frankel. I'm Nora Feldpausch. I am also a psychiatrist. I am the medical director at Mantra Health. So go ahead, Haley, if you would help us. We got Haley behind the scenes kind of running the slides. So welcome to Navigating ADHD in the college setting. Hopefully we're going to be able to have a collegial discussion on trends and best practices, and hopefully this is going to be useful for all of the folks out there that are trying to figure out how to navigate setting up protocols around ADHD and approaching this really important issue with students. So our meeting agenda, we are going to first start with introductions. Then we've got the Zoom poll that's already circulating. So if folks would take a minute to fill that out. We're going to share the data in that at the end, and then we'll also compile it and share it after the webinar, if you didn't hear me say that earlier. A lot of people have a lot of questions that they want to know what colleagues are doing nationally. So we thought if we got some sort of deep dive questions, and we could share that. And then I'm going to start out with just a slide overview, so just a brief overview of ADHD in the college setting, and then we will jump right into our panel discussions. We will have takeaways and resources listed at the end. So if anyone has questions about when we're mentioning CADRA, when we're mentioning NICE and other sort of ACAP, other organizations that have put together best practices, we'll have links to those at the end as well. And then we will open it up to questions and answers. So feel free to post questions as we go, but we'll hold off on answering them directly until we get to the end. Great. Next slide, Haley. All right, so I already mentioned I am Dr. Nora Feldpausch. I'm the medical director for Mantra Health. I've been in college mental health really my entire career. Started out at Michigan State University during my residency, and then afterwards in their counseling and psychiatric services clinic. Then I moved to Colorado State University, where I helped to build a multidisciplinary team focusing specifically on high-risk and post-hospitalization care. Went back to Michigan State remotely just before COVID, actually, and helped them get started with a telehealth program there. And then took over the medical directorship at Mantra when we were pretty small, and helped us to kind of build a clinic that is focused on evidence-based care, build our protocols, build our quality control, and eventually build our ADHD program again. So folks, we always have to put a disclaimer at the beginning. I am affiliated with Mantra. I am the PC owner of the clinic. I am going to try, however, to focus on the expertise of our panelists rather than trying to promote Mantra too much as we move forward. So, but I just wanted to sort of put that out there to be totally transparent. Dr. Hauxwell, do you want to introduce yourself and give us a little bit of background information?
Yeah, sure. So I'm Justin Hauxwell. I'm dual boarded in family medicine and psychiatry. I've been the medical director of behavioral health at the Health Center at Auraria in Denver, Colorado since 2016. I also helped to kind of streamline and formalize the approach for ADHD diagnosing and treatment in our setting. We're one of the sites that does not require neuropsychological testing for ADHD diagnosis and treatment. Our clinic serves not just students, but also faculty and staff. And so we do occasionally make diagnoses in professors and some older faculty and staff members. We also have primary care in this clinic. And so we take a fairly multimodal approach with our intakes, and includes a lot of medical information as well as psychiatric information. Hopefully that covers enough info.
Sounds good. Thank you. And Dr. Frankel?
Yeah, my name is Bettina Frankel. I came to the United States from Germany after the medical school and after having worked there a little bit in residency. After doing my residency in the US, I've been working at the Counseling Center of Northwestern University for a lot of years. And since 2015, our university started a sports psychology program, and I'm part of this. So I'm mostly seeing student athletes, but also regular students. And I'm the vice president of the Association for College Psychiatry, which I hope if you are a psychiatrist in a college, you consider joining, because I think a lot of us are kind of lonely, because they might be the only ones at the place where they work, or one of a few. I'm also a member of the ISSP, which is the International Society for Sports Psychiatry. Yeah, that's it.
Thank you, Bettina, for listing those out. Association for College Psychiatry, appreciate the plug there as well. I'm the Western representative for them, so feel free to reach out to me afterwards if you want to know more information for sure. Next slide, Haley. Fill out our Zoom poll if you haven't done that already. Would really appreciate that. So now we're going to just kind of jump in and talk a little bit. Talk a little bit about ADHD in the college population generally. So ADHD affects at least 5 to 6% of college students. That's on the conservative side, as far as the data shows. And ADHD carries with it a 6 times risk of developing depressive disorder and 8 times a risk for developing anxiety disorder, and is affiliated with lower GPA and graduation rates. In addition, we see a morbidity and a mortality associated with this illness. So it really is something that we should not be either ignoring or trying to work our way around diagnosing. It really does impact students pretty significantly. The multimodal treatment study of ADHD, which we cited in the end if you want to take a deeper dive, showed that those with persistent symptoms into adulthood were only a quarter as likely to achieve a bachelor degree. They went on to be more likely to have actually have their lifespan diminished by as much as 12 years over the lifespan. They were also less likely to be able to maintain work relationships, maintain individual and personal relationships over time as well. Early pregnancy is seen more often with untreated ADHD, more likely to end up on public assistance. And we need to remember that this is a disorder that does get diagnosed in college and graduate school, especially if the folks who are experiencing it were inattentive rather than hyperactive. Often they didn't get pulled out in grade school or middle school or high school. If they are intelligent enough to be able to work around their symptoms, it may be a college or graduate school before it really starts to get to the point where they can't just put their head down and power through this. Folks that were raised in traumatic environments may have had other behaviors or other survival strategies that interfered with them getting diagnosed with ADHD. And that is also true of students of low socioeconomic status, may not have had access until they get to college or graduate school to actually get connected with someone who can diagnose and treat. Next slide, Haley. So why diagnose and treat it? We already mentioned this. You see decreased social, educational, occupational, self-care functioning, higher rates of accidents and death from multiple causes, higher rates of substance use and addiction. And we'll talk a little bit about the concern of diversion of controlled substances on campus. But if you're looking at the individual with ADHD, there's actually a lower risk of substance use disorder if they are treated, as opposed to if they are untreated. And we have to remember that this is really a disorder that has an impact on the entire community, on relationships, on roommates, on interactions with the campus, and those sorts of things. So really treating one student is actually treating a whole community to better interactions and better relationships. Next slide. So barriers, there are a number. There are cultural barriers, of course. There are students that certainly come from areas in which mental health is not really considered something worth addressing. There is also the culture, I think, which is particularly prominent in some areas of the United States, that these are just kids who aren't disciplined enough and they just need to kind of put their heads down and push themselves through this. This is somehow a disorder of being lazy or something like that. I think that's a cultural barrier that needs to be overcome as well. The cost of diagnosis and care, and we'll talk a little bit about neuropsych testing and how that can actually provide a pretty significant barrier, especially to students from low socioeconomic status. It tends to impact students of color, minority students more significantly as well. Access to evidence-based diagnosis and care. I think when we look nationally, there are not a lot of centers that actually are building protocols that are evidence-based, that are looking at how to diagnose and treat this in a way that is effective and evidence-based. So I'm really excited for the folks that are joining today, because I think many of you are trying to build this into your centers, and I think that's really critical. There's stigma, of course, around any mental illness or getting treatment for mental illness. There's some concern from folks about medication side effects, and we'll talk in a minute about the fact that the medications that are most effective are stimulants. They are controlled substances, and trying to approach this without using controlled substances, unless there's a really strong clinical reason, is really not going to be as effective for students. And so then that leads to a concern about diversion. While diversion is an important piece that we need to pay attention to, need to build protocols as best we can around, there is not a lot of data sort of saying what actually prevents diversion and what does not. But there is a good bit of data suggesting that if we avoid prescribing because of fear of diversion, we will negatively impact student outcomes for sure. Next slide, please. All right, so diagnosis is something that really has to be holistic. One of the things that we have to sort of push on schools a lot is to understand that it is a little bit expensive to diagnose this disorder. You have to invest in very skilled clinicians. You have to invest the time that it takes to do a really thorough deep dive into developmental history, into whether there was impairment in childhood or not, whether there's impairment across multiple settings. You need to rule out other causes of trouble with focus and concentration. Remember, there's a high comorbidity with this disorder, with depression, anxiety, both of which can masquerade as ADHD, poor focus and concentration. That's also true with PTSD and other disorders. Substance use disorders, chronic marijuana use can impact focus, concentration. So we really have to look holistically and take the time to make sure with our protocols that we're hitting on each of those points. We'll talk in a little bit about the various screening forms that we use. There are a number that are validated, and they tend to be very useful, both looking at parent or childhood caregiver scales, individual scales. Those inform the diagnosis, but the real diagnosis comes from a good clinical interview by someone who's well trained to understand this disorder and to diagnose it. Next slide, please. The one thing I will say is that scales alone do not actually accurately diagnose ADHD. They are ancillary to a deep clinical interview. And we're going to talk a little bit about neuropsych testing as well. This is from an article published by Aaron Winkler, who's out of Stanford. He heads up their ADHD program there. Dr. Frankel actually was also part of helping to get this article written and published. Oh, Dr. Winkler's there. Hi, Aaron. Nice to see you. So Aaron, I'm going to quote you rather than letting you quote yourself here, but basically what he said, and I would really encourage you, we have this article in our resources at the end. I would strongly encourage you to read it. It does a very nice job of looking at ADHD across the spectrum and really doing a deep dive and guiding college mental health folks in how to address ADHD. So Aaron said, the gold standard for diagnosis is a comprehensive clinical interview informed by reports from others who know the patient. While universities often demand neuropsychological testing before offering medication, there is broad agreement among researchers and clinicians that this is not scientifically justified. In addition, what you'll learn from that article is that this age group, 16 to 39, is when neuropsych testing is least sensitive for ADHD and misses as much as 50% of the disorder. So while neuropsych testing has its place, it does not belong in a requirement for allowing a university to diagnose ADHD, and in fact can be particularly problematic for students who don't have resources, because it can create a barrier that students without resources cannot jump over, and that really puts them at a disadvantage. Next slide. Gold standard of care, stimulants plus individual group-based psychotherapy, and medication is highly effective, but it is just one arm. So you really do need to approach this as a holistic diagnosis for the whole person, not just medication or just therapy. Next slide. So there are educational and occupational interventions. Interestingly, less than half of those with ADHD register with the Office for Disabilities. We're going to talk a little bit more about how integrating the Office with Disabilities can be helpful. I think there was already a question that came in about how do you work with this? What kind of accommodations are useful? So we can talk a little bit about that. Psychosocial treatments, coaching, exercise, group-based skills training, even DBT and CBT both have been shown to be helpful. Metacognitive training, mindfulness. If you want to look at a well-developed sort of holistic approach, access is a treatment that has been shown to be very helpful. And then we want to make sure that we're treating medical comorbidities as well. If we get a chance at the end, Dr. Winkler over at Stanford is starting to really build a program there that looks at all of these aspects as well. So I think he'd be a good colleague and resource. Next slide. So I think the critical thing that I would put forth, and we'll talk to Dr. Hauxwell and Dr. Franklin in just a moment about this, is that you really do need to be thoughtful about how you put together your approach to care. It needs to be evidence-based, and it needs to offer diagnostic clarity. It needs to be holistic, take into account the whole person, look at medical issues, look at developmental issues, look at psychiatric issues, and it needs to be the same for every student. And we cannot put arbitrary barriers like neuropsych testing in the way unless they are appropriate for that particular case. In the same way, we have to have access to care for all of our students. I know there are a lot of universities that will send folks off campus. While that can work, you need to be able to make sure that all of your students can access those resources equally. Next slide. Okay, so we'll share resources at the end. Haley, if you want to turn the slideshow off, we'll get back to talking with our panelists to kind of really jump in here. So, there really are a few consistent approaches that I see nationally to treating ADHD. I think, Justin, you do a really nice job, and we'll explain in a minute about how your college university system approaches this with evidence-based protocols, with psychiatry embedded within primary care. So that is one approach that we do see working effectively. We also see campuses that have a single psychiatrist that can diagnose. This can be effective as well. I do think it's important to make sure that that psychiatrist is really following evidence-based, up-to-date standard of care, and that all students can access that person as well. We also have campuses where primary care will handle medications. It can be a little bit tricky when you're trying to decide protocols for students who've been diagnosed before they came to the university. And if there are overlapping mental health concerns, that can get tricky as well for primary care to handle without support. There are, believe it or not, some colleges and universities that just won't touch ADHD, and they just say, go out in the community and find what you can, and we're not going to deal with it. And so I think that's just something to acknowledge, that there are universities that do that. And then I work with a company. There are some universities that I did turn the PowerPoint. We turned the PowerPoint off. Lisa, thanks for letting us know. We're going to jump into the panel discussion now. We'll give you access to that afterwards if you need it. But we've developed a third-party way of kind of collaborating with schools, and we'll talk a little bit about what I would advise as far as best practices for choosing and creating that type of program. But moving forward, I'm curious how each of our panelists kind of arrived at the protocols that you have. So if you want to explain for a little bit what you're doing, how you developed those protocols, what you require, and how you got there, and what's working, not working, that sort of thing. Dr. Hauxwell, do you want to kind of jump in and lead us off first?
Sure. Yeah. I'll start out by saying that because we're a multi-specialty clinic, all patients who establish care here as new patients fill out a certain amount of new patient paperwork. And that includes a pretty robust social, family, personal medical history. And that includes patients who are just establishing care for mental health. If a patient comes in with an explicit request for ADHD evaluation, then we have an additional series of forms that are really based around the Vanderbilt questionnaires. And we modified and added to those, branded them with our own sort of health center logo and all of that, but expands on the historical pieces that are included in the new patient packet, includes all the 18 diagnostic criteria, but also that medical history, more detailed questions about elementary, middle, and high school timeframes, symptoms. So there's a form that a parent fills out, or a childhood observer, we call it. Not everyone has living parents. Not everyone's parents are involved in their lives. That includes some developmental questions. Was there substance use in the mother during pregnancy? Did this person have developmental delays? Any of those kinds of things. And then we also have an adult observer, which is usually a roommate, a partner, sometimes a professor, to try to capture that whole robust wraparound series of observations. It's worth mentioning that many students come in for mental health care not explicitly seeking ADHD care, but still probably with ADHD. And to try to ferret those people out, we also have everyone fill out an ASRS as part of their just general mental health intake. And that has helped lead us to diagnosing ADHD in people who would not have suspected that they had ADHD, and yet it was a critical part of their dysfunction. Is that adequate for right now?
Yeah, thanks. I think that's adequate
Yep.
for right now.
Okay.
Dr. Frankel, do you want to sort of explain your thoughts here? Oh, I think you're still muted.
Our approach is not quite as comprehensive. We, I think, worry a little bit about students filling out too many questionnaires. So we try to keep it short. They fill out the questionnaire that's related to our electronic medical records that allows us to follow certain things. We also, if students try to make an appointment just for ADHD evaluation and treatment, we give them, we have care coordinators. We set them up as care coordinators and we refer them out. The reason for that being is that we have a brief treatment model. We don't see people longer term. And if you just want ADHD and nothing else, then that's clearly a long-term issue. And so it's better to start with someone in the community. Now we are in Evanston, Illinois, which is a suburb of Chicago. We have a lot of resources around us. Not that there's no wait time, there is. And all of our students have to have insurance. In order to be enrolled at Northwestern, you have to have insurance. And we don't have the insurance anymore that a lot of international students have had, that was just covered in the case of like catastrophe, like an accident or something. We have every international student has to get our student insurance. We call it NU-ship. So everyone has to have that insurance or something equivalent to it. So psychiatric appointments and diagnosis should be covered.
Mm-hmm.
For students that are in therapy here or have or present to our clinic with, you know, something like, I don't know, I treat for depression, anxiety, or ADHD is part of a package, and they are in treatment here. Once they are in therapy at our center, we see, and it is believed to have ADHD, we see them for ADHD evaluations.
Mm-hmm.
And that, similar to what Justin said, involves filling out the evaluation. It was thorough clinical interview, you know, talking and thinking about comorbidities and stuff, then questionnaires for themselves, for an adult observer and a childhood observer. We have the WHO and a modified Vanderbilt thing going.
Mm-hmm.
And then we also always get, which was part of the gold standards you presented, we always talk to someone who's known them from their childhood. Now, I've talked to people in, I don't know, in Norway and in China who don't speak English, and they often have someone there, like an older sibling or sibling, and that often gives. So Zoom actually has made that a much more cost effective. I've done this for years and it's been very expensive, but this is so now it's better. So, you know, just as Justin said, often there is not a parent, or a parent is culturally or for whatever reason completely opposed to the kid being diagnosed with ADHD, then we try to get another childhood person who's known them before the age of 12, really, which is what the diagnostic criteria is.
Yeah, that can be really difficult, I think, especially in graduate students and in students from areas where they haven't been diagnosed previously, for sure.
I have not found many people who keep their elementary school report cards that say very chatty, and so that's a problem. That is, so talking to a caregiver really is the gold standard.
Yeah.
And for international students, sometimes English is the barrier for the caregivers.
Yeah. We do, I think, a very so Mantra is a third-party telehealth, but we embed into the existing counseling system. So we can embed into the system on the campus, so we can access disability and therapists on campus, and even in some cases primary care and that sort of thing. We take a very similar approach to diagnosing. I think we use the Vanderbilt Parent Childhood Observer, although that is the one piece that we will allow to slide if we have to, because there are cases where you just can't get it. That said, we do the ASRS V1.1, and we created our own student questionnaire. Stanford actually has a really nice one that you can take a look at online as well. That included some of the screening programs, questions, but it also includes a broader look at things like, have you been in car accidents? What do your relationships look like? You know, those sorts of broader background. We gather all of that before we do the first clinical intake with the student. And then we set aside a full hour, really do a very deep dive into developmental history and those types of things, which I think is really critical. I know we've had a lot of folks ask questions about, what about students that have already been diagnosed? I think there are various approaches to that. The approach that we took, and Justin, I'd be curious, and Bettina, how you did this, but we took the approach that they had to show us that they were diagnosed via standard of care. So they needed to either have been diagnosed by a psychiatrist within the last 4 years, or primary care could provide us with the screening and the intake that looked thorough enough to be able to say, yes, this is ADHD. Those folks often can be siphoned off to primary care if they're not complicated. Then we created an algorithm for what's complicated, typically substance use disorders that are comorbid, other mental health disorders like bipolar 1, those kinds of things. Those we would co-manage with primary care, so that they constantly had that sort of that feedback and support. Justin, what are your thoughts about you know, creating these kind of protocols for students that are coming in with a diagnosis?
In our case, we will request or require rather that the student fills out a release of information to the prior care provider who had made the diagnosis. We still will do our own independent evaluation for ADHD. So that's just value added, any records that we can get, but we'll still do our entire ADHD evaluation. My own practice style is very direct with students who come in with a prior diagnosis in telling them that I will do my own assessment, and that it's unusual that I will prescribe medicines on the very first visit. An exception might be if they come in already on a medication and it's well established, and they provide a thorough report and history of its effectiveness. And especially in our state, if I can look them up in the PDMP, the Prescription Database Monitoring Program, and I don't see any irregularities, any doctor shopping, that builds my confidence in the student's use of the medicine appropriately. So there are some limited circumstances where I may prescribe earlier. But my practice is to do my own evaluation, no matter how thorough the previous evaluation looked, including all of the additional psychiatric discussions, so mood symptoms, anxiety, sleep, head injury, OCD, autism spectrum, including all of that material.
Mm-hmm. Bettina, does that sound similar, or do you have anything to add?
Well, we don't continue for just ADHD, but our health service, we are separate from our health service. I know a lot of psychiatrists are embedded in the student health service. We are separate. Our health service is, I think, evaluating their policy and might be changing their policies, whether they continue people, and that is currently changing. So there's not.
Mm-hmm. Mm-hmm. there's some questions coming in about executive function coaching and sort of wraparound services. And we'll take a minute to talk a little bit about disability services. I know that that's something we built into our program as sort of evidence-based, that we've got the diagnosis piece, we've got the protocols around how to diagnose and what should be included in that, what has to be included in that in order to make the diagnosis. And then we also add coaching and psychotherapeutic support to really create sort of a holistic wraparound program. Are others also doing that same thing, or how do you manage the coaching or the psychotherapy support side of management of ADHD?
Justin, or should I go? Okay. So that is when people are in therapy, that's the only time we really prescribe medication. Then they are getting individual kind of therapy and addressing of their ADHD and their comorbid issues. But I wish we would have groups that address this. I think that is something that is lacking here. And we see some students, mostly student athletes, for a little longer, because they have trouble connecting to resources or, off campus because of the schedule. But I think there would be a chance to have a group for those people we see a little longer, or that's would be something I would want, but we don't have.
Mm-hmm.
I have a similar discussion with patients about, I've called it ADHD life coaching. I don't know if that's the same as executive functioning coaching. That is not something that we have in our facility or really on our campus. I should mention for context, the Auraria campus in Denver is a very unique campus. I think it's now the only one in the country like this. It's a single shared campus that serves 3 schools. So there's the CU Denver, the Colorado University at Denver, a 4-year school called Metro State, and a 2-year community college of Denver. So there are 3 independent schools, all sharing a campus. We're the health center that serves all 3 schools. Each school has their own counseling center where students would see therapists. So we will collaborate, coordinate with therapists at each school for individual patients. And in those therapeutic settings, they can get some of that kind of skill building around ADHD. But for more formal EF type coaching, that's going to have to be out in the community.
Got it. Shifting gears just a little bit, I know there's often concern on campuses about diversion of stimulants, and I'm wondering how each of you address that in terms of in your diagnostic process or in your treatment process. There's been talk of having contracts with students, checking PDMP. How do you, doing urine drug screens, how do you talk with students about that, and then how do you work that into your protocols?
We decided to require a baseline urine drug screen for anyone who's going to be prescribed a controlled substance in the psychiatric setting. And that came about through some discussion and some interactions with specific patients. It used to be provider discretion, and that was too nebulous. So we decided to require that for all students presenting for ADHD evaluation. And that's just become accepted amongst the student body. We really don't get any complaints about that anymore. In terms of ongoing monitoring with urine drug screens, that remains provider dependent and kind of patient dependent. I've been, I suppose, lucky and not stumbling across very many people who at presentation had anything in their urine really other than marijuana, which is legal in Colorado. And on the few occasions that someone came in and did have cocaine or amphetamine in their urine, it facilitated a really handy discussion. Sometimes that led to me declining to prescribe to a certain person. Other times, the context made so much sense that I cautiously prescribed and checked them on subsequent occasions, and they never showed positive for cocaine again, because once their ADHD was treated, they had no draw towards that anymore. We also require all providers to check our pharmacy database, the PDMP, prior to prescribing and prior to each visit. And that's part of our workflow. It's very fast. There haven't been any campaigns or anything on a campus-wide basis related to the phenomenon of diversion. Of course, we know it still happens. Part of my questioning of any patient at intake is, have you ever borrowed or taken anybody else's mental health medications that weren't prescribed to you? And I feel like I get very honest answers. People tell me if they borrowed their roommate's Adderall, and I lightly chastise them, but also use it as a learning experience, because if they took it and they said, I felt terrible, I didn't like how I felt, that's meaningful information. If they say, I took it and I actually sat down and studied, I felt relaxed, I felt like a normal person, that's also information I might be able to use, whether or not I ultimately agree with that diagnosis. So that's our approach here.
Got it. Bettina, anything different about
Yeah, I see almost all athletes, so they get tested for drugs anyhow. So but I do get a urine drug screen, and you know, that's just my feeling for my impression with the regular campus. There are so many students who get prescribed the stimulants from home or through some maybe not what we would consider solid or nice or good telemedicine. I feel like there is, if students want to use stimulants to abuse them, they can. And if they have ADHD that's untreated, they will, because the ADHD is untreated. Not all of them will, but a lot of them will. I have not seen, I do some urine drug screens once in a while, but I have not seen students, because I gave them stimulants, develop a substance use disorder. That is not how I see it. Maybe students have a substance use disorder, then that has to be addressed. But what we do tell all students is, we used to have an agreement, that a lot of people have, that spelled out not sharing, not selling, and those kinds of things. And we backed away from that, because it's really just part of teaching, of educating the students about the medication. And it's not enforceable anyhow, and it puts you in a kind of law enforcement role, even though you are a medical provider. So we document that we've talked to students about that, and that's, it takes a little bit of time in the session where we decide to prescribe, and it does take some time to document, but that's just what we do. And we don't, we tell them we don't replace things if they lose them. And
Yeah, I think they're having policies around, I think checking the PDMP before prescribing is really truly standard of care. I've in the past.
That's the law in Illinois. Your electronic medical record has to be connected to the Illinois prescription drug monitoring program. And
interesting. Okay, I think that's not a national thing. So that varies from state to state. I sometimes have used the agreements as a guide to make sure, especially when I'm supervising a group of clinicians who are diagnosing, to make sure that everybody is really doing a good job of informed consent. So we don't use that as much as a sort of like sign this or else kind of situation, but as this is documenting that we've had this discussion, and you understand that if you lose it, you need to make a police report before you can get another one, and those sorts of things. I think it helps to make sure everybody's kind of very much on the same page. At Mantra, because we are doing the diagnosing and then the psychotherapeutic treatment, but are working with primary care who's doing the primary prescribing of the stimulants, we defer to whatever policy the particular university ascribes to. And I will say they are variable within the same town, even across campuses at times. So, I think there's not a lot of agreement. And again, I think the Winkler and Frankel article, I think, addressed this a bit, that there just is not a lot of great data around whether any of this actually prevents diversion or not. I think you are sort of deciding whether you prioritize treating those students whose morbidity and mortality is significantly affected for an illness that they have that they can't control and needs to be treated, versus whether you prioritize those students who are using stimulants illegally. I think you kind of have to weigh out the risk benefits of those two policies. And the students that are using stimulants illegally, I think you are more likely to see that happen in students of means, less so than in students who, and you're more likely to see students of color and students of minority groups underdiagnosed and not getting the treatment that they need. So the question is, whose needs do you prioritize in that situation?
Well, the students who are, if you had to make a stereotype of an abusing student, it's a white man in a fraternity.
Yeah.
So, but I discuss with my students, and I don't know whether you do, Justin, and you do, Nora, I discuss with the students when I start them on stimulants that preferably not to tell their friends. I discuss with them the thing that students with ADHD, because of their social shortcomings and the social effect of the ADHD, often are so dependent on being liked by their peers, that I tell them to avoid, like, be a good friend, give me a stimulant for the exam kind of thing, to not let people know that they're taking stimulants.
Yeah, I agree, and to tell them how to secure them. I'll just reiterate
lock them up.
Bettina, that was in your article, was that the most likely to be taking stimulants around exams and things like that aren't prescribed are white men in fraternities. So those are the folks you are protecting by not prescribing stimulants to students with ADHD. And I think that's just important to sort of reemphasize. You're not pulling that stereotype out of your head. That actually is based on data.
I also,
go ahead.
But it can be helpful too to remind them that that's a felony.
Yes,
and
I do.
That'll
remind
usually
them
make their eyes really big,
Yes.
and I think most of the time the conscientious students hear that, like, "Whoa,
Yes.
I'm not giving this to my roommate now."
Yeah, absolutely. That is important to mention, that that is actually a felony. So I'm going to jump ahead because I'm keeping an eye on the time a little bit. I want to get some time to go through the poll and also to answer some specific questions. But sort of final takeaways. How do you, if you're advising a colleague who's been tasked with addressing ADHD care on campus, what sort of key pieces of advice would you want them to take back to their school or to their organization as they start to build out these protocols?
I think standardization feels important. I was thinking about this during the discussion. There's a certain amount of this diagnosing and treating that I think is very amenable to standardization. And then there's an aspect of it that is not a one size fits all. And so you have to live somewhere in between. I think getting people through the gate with a standardized process is valuable. Once they've landed in the chair across from you and you feel confident in the diagnosis, then that's where I think the nuances have to start showing up. And that includes things like substance use, comorbid medical or mental health diagnoses, social status, or social circumstances, and all of those things. So I would say, the upfront stuff needing to be standardized, the questionnaires, the evaluations, the practice approach at the clinic. You can't have 3 different providers doing 3 different things to bring students in. But then after you've cleared that kind of standardized stage, then you have to do a much more personalized approach with the person who's sitting across from you.
Got it.
I think what's really important, I agree totally with what Justin said, but I think what's really important from my point of view is so many of professionals in our field, whether it's, not just psychiatrists, anyone, believe still that neuropsych testing is has to happen in order to have ADHD, to make the diagnosis of ADHD. And that just really is not the case. And that is important to know. And I think also third-party contact, for me, that is often crucial. Because a student might not say much, but then you talk to a parent and say, well, they never were able to see circle time, and they are whatever, not able to sit still or this or that, and you understand and you get a better impression. To me, third-party information should be part of that standard protocol.
I think if I had advice to share, I would say a couple of things. I think, first of all, there are multiple ways to approach this effectively on campus. I think if you have, if you have CAPS on campus, if you have, primary care with psychiatry embedded together, I think you can create a standardized protocol that works well for students. I think if you're embedded in a community that has good resources, you can potentially refer to those as well. I do think it's a nice idea to kind of screen or get to know those folks who are doing those diagnoses in the community, because we really want to make sure that they're following evidence-based. I mean, obviously, I think, a really well thought out third-party, person like Mantra, I believe that, our approach can be very helpful and useful for embedding within the existing school procedures, if that's something that feels like it would work for your school in terms of bringing resources. So I think there are multiple ways to approach this that can be effective, but I think the basic that should be there in every case is the protocols. I think we'll share at the end. NICE, NICE, and CADRA, CADDRA, are both two organizations that do a really nice job of listing out, here's your choice for evidence-based screening problems. Here's your choice for how to make this diagnosis and what should be included, those kinds of things. So I think to create that protocol, no matter what your approach is really critical. And then I think continuing to try to make sure that this type of service is available to all students and you're not creating arbitrary barriers for some or others is really, really critical, because that's really an issue of access and of access to care for all students, not just those with means. So let's switch over and see if we can share the response to the poll. Let's see if we can share that with folks. And again, we're going to share the recording of this, but we're also going to sort of put this together so everybody will get copies of this for later. So don't feel like you need to scribble this down real quick as you're looking at it. So about a third looks like they're affiliated with a college facility or center that's able to diagnose ADHD in-house. So quite a few then are relying on either bringing in third party or relying on local community folks. And then it looks like more than half require neuropsych testing. So I'm glad those folks are attending today, because I really do think that is a critical piece of access that might need to be addressed in terms of requiring something that really isn't evidence-based and that often can create a barrier to care. I know Aaron has been making some comments, Aaron Winkler's been making some comments, and I know he feels really passionately about this and about that actually being a way of disrupting student access that really is harmful. Let's see if we can see the rest of the poll. Can we, oh, I can scroll down, there we go. Okay, so less than half have the ability to prescribe ADHD at their center. That's consistent with what we see nationally. It looks like psychiatry prescribes about a third. Primary care is a pretty small percentage. I know at Mantra, we do work with primary care, but we also have psychiatry advising, because it can be really hard for primary care alone to really deal with some of the comorbidities that come along. Some have both. And a lot, it looks like that's just reflecting the folks that don't prescribe at their school. It looks like the vast majority do not have clear protocols or treatment standards. So it sounds like, though, I think the attendance at this webinar suggests that maybe that's changing. And it looks like only about a quarter of those that do have those standards actually require an interview. And then we'll just look through. So most needed looks like ADHD diagnosis and support across the board is broadly needed, little less so medication management, coaching groups broadly needed, training and learning for providers broadly needed, resources that are digital for students also broadly needed, and very few say they have no services. I think we got a little bit of a biased audience too there, right? Because they're the folks that are coming to try to learn more about how to create these services. Let's jump over and see. This is really interesting. So someone asked, is there any way to advocate for policy change around requiring neuropsych testing? Because sometimes that's being implemented outside of the, sort of higher up. Thoughts about that, Justin?
I'm not sure I'm the best person to answer this because I had plenty of buy-in from my administration. In fact, it was universally agreed upon in our setting not to require neuropsych testing because at least 2 of the institutions on this campus are filled with non-traditional students, many of whom are working full-time jobs and taking classes part-time, or who are out of institutes of corrections, older students and students of lower means. So it was felt just in our kind of policy at our clinic that it would be a barrier. So it wasn't even really the conversation about the accuracy of that type of evaluation. It was more about access and means. And that's why then the onus was on us to create our own process of trying to make that assessment. There were some questions in the chat about how do you, in essence, filter out potential malingerers. The intensity of our packet is one way we try to do that. It's a little bit beefy. And I do think that helps to cut down on the people who are just trying to get a quick fix with a prescription. They have to actually do the work and take these steps. So I think that has helped. I guess that's what I can offer for that question.
I think this is really, and that's how I would argue if I had to. Northwestern, I didn't have to argue. We clinicians basically decide what we want to do, and this is what there wasn't administration. But if administration is using neuropsych testing as a gate, which is basically as a bottleneck to reduce the amount of stimulants that are prescribed on campus, which is how it's often, how I would see it often. I think one can really say this is a social justice issue. This is something that doesn't get picked up in schools where teachers are, that are more chaotic, where teachers are less resourced, where a lot of our more disadvantaged students have gotten their education. In those elementary, middle, and high schools, it doesn't get picked up often. It's an issue where many cultures do not support diagnosing it in their kids. So we might be the first ones doing it, and then putting a block in the way of the students that is very expensive and not scientifically justified. There is no research that backs up that this is the right approach. That I think should convince most, I don't know, but I would think should convince most administrations.
Yeah. I think it's not much different than saying, we're going to start bleeding people for strep throat. It's like, nope, that's not evidence-based. We're not going to do that in our center. I think you kind of have to sort of push a little bit as far as that goes. There was a question in the recommendations for students who are accessing online treatment to access medication without a thorough assessment for ADHD. I think this is not just limited to online, right? We see a lot of students that come in that say, I mentioned in my primary care that I can't focus, and they started me on Adderall. And you'll ask, okay, well, how long did they talk to you for? 15 minutes. Did they ask you a developmental history? No. So I think this is a more broad sort of question. And I have to say that when this happens via telehealth, it hits really close to home for me. I think when you are vetting telehealth services that you're going to be offering to students, you need to ask them, or do you treat ADHD? How? Let me see your protocols. Let me see how you diagnose it. Let me see how you treat it. So the telehealth piece is becoming less and less of a problem because the Ryan Haight Act has not been overridden yet. So like for Mantra, we don't prescribe stimulants. We do diagnose ADHD, and then we work with primary care to help them prescribe for just that reason. So there's a lot of cracking down going on these telehealth companies that are interviewing for 15 minutes and then handing out stimulants. But generally, I think there's only so much we can do because a student always has the option to go off campus if they want to. But I think offering accessible care in-house that is evidence-based is going to help a lot in terms of not having a student have to rely on less reputable sources to get what they need. So I think that would be my comment on that. We are almost to the end. We have 3 minutes left. Let me see if I can grab one more question. I think there are some questions around cost. So how do you cover the cost of this? The cost of this treatment? I mean, I might argue that there's a pretty big cost to not treating it, especially you're talking about students not graduating or dropping out of school or dying. But Justin, Bettina, in 30 seconds or less, how would you advise folks to think about the cost for this type of care?
Well, there's several layers to that. I mean, there's the evaluation and the office visit fee, if there is one, and then there's the prescription. For prescription stimulants, generic stimulants with no coverage, you can use the GoodRx coupon. It'll knock the price down quite a bit. Sometimes it'll affect your prescribing recommendations, and you may adjust how you prescribe the medication, or which one, or what frequency, to help the person utilize the script for a longer period of time. Those are just some quick comments.
Great. Bettina?
Yeah, I'm not sure that I have any comments. As we are part of the tuition fee, for us the diagnosis, our time is paid by the university. We don't have to bill insurance. I think a lot of centers do bill insurance, so that's different for us. And a lot of the medications are generic, but still very expensive.
Yeah. Well, we're wrapping up here. I know we could probably talk for several more hours. We're going to share the resources. For those who are interested, we'll also share a link to Mantra if you want to do a deeper dive into their telehealth approach and kind of what we're offering. And then we will follow up also with sharing the Zoom poll so that you'll have those resources at your fingertips as well. Thank you so much for taking the time to sit and listen to us and to think through this really interesting and challenging problem of how to diagnose and treat ADHD effectively on campus. And we will also take a look at some of the questions we didn't get to and see if we could possibly maybe have our panelists continue to answer some of those and or send out some more resources as we go as well. Looks like we're already having folks ask for a part 2. So we'll have to see, Justin and Bettina, whether we can arm twist you into coming back. But thank you so much for both of your time and for the work that you're doing on behalf of students as well.
Okay.
Thank you.
Bye. Thank you for
Bye,
having me.
everyone.